The general supplies you will need to conduct a screening include a vision screening record form, a measuring tape or yardstick, masking tape, pencils or pens, paper clips and a stapler, plain paper to tape behind a wall chart if necessary to provide an uncluttered background or to cover windows to reduce glare, 2 small tables, 3 chairs, 1 each for the screener, recorder, and chart attendant, a wastebasket and trash bags, name tags for the screeners, extension cords, tissues or handy wipes, rewards for the children, such as stickers, coloring pages, or ribbons. There are also specific screening materials that are required: a Leia visual acuity chart, a pointer, Happy Magic Feet for preschool-age children, occluders, preferably disposable, 1 per child. Construction paper fish or pirate patches that the children may color in class work well. Small paper cups also work well. A light box, the Random Dot E Stereopsis kit, adult and pediatric size polarized glasses, 2 test cards, and 1 demonstration card. Alcohol swabs. A successful screening requires an area with as little distraction as possible. These are things you should look for in a screening area: a quiet area free from disturbances, a room with sufficient space permitting viewing the chart without obstruction. You will also need 12 feet of space for the 10-foot chart, an uncluttered, non-patterned wall, appropriate lighting without shadows or glare. There are 3 major roles in conducting a screening: the screener, who must be certified by Prevent Blindness America, a chart attendant, a recorder. In an ideal screening, all roles are filled by certified screeners, but at a minimum, 1 person must be certified. Responsibility for the screening, testing procedures, and referrals lies solely with the certified screener or screeners, regardless of which roles they fill. Depending on the number of individuals available, the screening may be conducted by 1, 2, or 3 screeners. Although it is highly recommended that there be a minimum of 2 screeners for preschool screening, 1 screener can conduct all aspects of a school-age screening. The screener's responsibilities include managing the overall screening, assisting in setting up the screening area, greeting the children and establishing rapport with them, observe signs of potential vision problems, determine the practice and referral criteria for testing, screen the children in acuity and stereopsis, watch to make sure a child's eye is properly occluded. The chart attendant's responsibilities include assisting in setting up screening area, pointing to the proper symbol, line, watching for proper occlusion, assisting the certified screener in observing signs of ABCs. The recorder's responsibilities include assisting in setting up screening area, completing forms, noting screening results and recommendations, watching for proper occlusion, assisting the certified screener in observing signs of ABCs. Distance visual acuity screening may be done using any of the PBA approved charts. Either a wall chart or a lightbox version is appropriate. However, visual acuity testing machines are not recommended for young children. Approved charts include an HOTV chart for preschool-age children, a Lee Symbols chart for preschool-age children, an ETDRS chart for older students, a Snellen Letters chart for older students. Please remember that Prevent Blindness America's protocols are subject to change as new procedures and approaches to vision screening are developed and tested. To set up the screening, select a space for the Lightbox and Leia chart that ensures an unobstructed view. Select a space away from windows to avoid glare or shadows if possible. Close window treatments or hang plain paper over the window to reduce glare. Hang a 3-foot by 3-foot piece of plain paper as a background over a cluttered wall. The passing or critical line should be eye level with the child to be screened. This is generally 40 inches from the floor to midway between the 2030 and 2040 lines. Ensure that the chart is adequately illuminated. Normal room lighting is sufficient. Once placed, make certain that the chart is clearly visible and that there's no shadow or glare cast on the chart. Measure off and mark 10 feet. Mark the floor with masking tape or Happy Magic feet. The heels are placed at the 10-foot mark. Place a chair and pointer near the chart. Place a table, occluders, alcohol swabs if necessary, and wastebasket near the testing line where the child will stand. Place a table, chair, and record forms at the recorder station, typically off to the side midway between the chart and the child.
Vision screening really encompasses three components. The screener is going to look at the A, B's, and C's of that child. A is appearance. What does that child look like? Does the child look like they have straight eyes? Is there an eye that's raised? Does a lid droop in that child? What does that child look like? If there's an appearance that there's a problem, then that screener is going to refer that child to an eye care professional. B is going to be behavior. Does the child have a hard time seeing? Is he squinting? Does he have a strange head tilt when they're trying to examine the child? So is the behavior of that child age appropriate for the child? And then C, complaints. If the child is old enough to communicate that they're having a problem, what kind of complaints do they have? Do they have pain in their eyes? Do they have headaches? Is there eye strain? So the A, B's, and C's of the vision screening is going to alert the screener to the possibility that that child may have a problem before they even try and check their vision.
As the screening begins, greet each child. This makes the child comfortable and may put him or her at ease. This also provides an opportunity to observe potential eye problems. Children, especially very young children, may not sense or complain about discomfort or visual difficulties. Parents and classroom teachers may have picked up on various signs or have noted comments from a child to indicate a possible problem. Observation of any of the following signs is sufficient reason to refer a child for an examination. In such instances, it is not necessary to proceed further with the screening. There are three types of signs of potential vision eye problems that screeners may observe in children. Thinking about these three ABCs, appearance, behavior, and complaint, can help the screener with this initial observation. The A, or appearance, is how the eyes appear upon visual inspection. Are the eyes crossed or wall-eyed? Do the eyes water? Are the child's eyelids red-rimmed, encrusted, or swollen? Is an eyelid drooping? This is called ptosis. Is there a sign of a stye, an infection on the eyelid? Is there a presence of a white pupil? This may also be observed on a photograph and as a possible sign of retinal blastoma. Is there a possible eye injury? Watch for eyes that are reddened, bloodshot, blackened, bruised, or swollen, or evidence of lacerations or abrasions. The B, for behavior, requires looking for signs in the child's manner, stance, or vision-related habits. Is the body rigid when looking at distant objects? Does the child thrust his or her head forward or backward while looking at distant objects? Does the child's head tilt to one side? Is there any observed squinting or frowning? Is there excessive blinking? Does the child close or cover one eye? The C, for complaint, requires looking for signs that would indicate discomfort or illness. These might include headaches, nausea or dizziness, blurred or double vision, burning, scratchy, or itchy eyes, sees blur when looking up after close work, unusual sensitivity to light. There are two possible initial outcomes of the ABC screening. Either the child passes and proceeds to the acuity testing, or the child fails and must be rescreened at a later time. The definition of visual acuity is the keenness or sharpness of perception. It is the ability to discern fine visual differences. Research shows that a distance visual acuity test is the single best index for determining the existence of visual problems in children. Visual acuity is typically determined by having a person read a standardized vision stimulus, such as an eye